Hi there, I'm Dr. Teresa Caraway, CEO of Hearing First, and welcome to our Facebook Live Ask Me Anything event. We're broadcasting from Oklahoma City, Oklahoma, our hometown, which is nice to be in our own space. But a bit about Hearing First, and at Hearing First, we believe every family needs to know the status of their baby's hearing first because all child development hinges upon that. And so we provide awareness about the importance of newborn hearing screening, the awareness that today babies who are born deaf can learn to listen and talk just like their hearing friends. And we also provide education to professionals as well as families. And we have two communities, online communities. One, a family-to-family support community, and an online professional learning community. So awareness, education, and communities are what we're about. And I'm excited because tonight I have a very special friend and colleague, Dr. Stan Baker, who's a neuro-otologist and a cochlear implant surgeon and a hero of mine. And it's been terrific over the years to get to partner together and work together. So I'm excited about the discussion that we're going to have tonight because we're talking cochlear implants and babies and young children. And it'll be a great conversation for us to have and to hear from his perspective as a neuro-otologist. How long have you been doing cochlear implants now?
Long time, Teresa, 25 plus years.
Yeah, there you go. So a little bit of experience here that we get to tap into tonight, which is great. And Dr. Baker, his practice is Otologist Medical Clinic here in Oklahoma City, and we'll be telling you a little bit more about that as we move along this evening. But welcome, and we're inviting you to submit your questions by posting them in the comments section below, and we look forward to answering your questions this evening. So I think the first place to start is, Dr. Baker, tell us, what is a cochlear implant and how does it work?
A cochlear implant, it's an electronic bypass for an ear that doesn't work. And it has two components. Briefly, there's an outside component that's much like a hearing aid, a little more complicated than a hearing aid, but you can think of it that way. And it's the outside component gathers sound, processes it electronically, and then transmits an electronic message to the inside part. The inside part's what we put in surgically. And it's called a cochlear implant because it has an array of electrodes that are put inside of the cochlea. The reason we do that is because that gives us good close approximation for those electrodes to the hearing nerve. In most cases where the cochlea stopped working or never started working, the hearing nerve, the cochlear nerve, still works just fine. So if we can provide an electronic substitute for a cochlea that's not working, the hearing nerve picks it up and thinks it's real sound. And in fact, it is real sound ultimately.
Yeah, and so that brain adjusts to the new signal that the cochlear implant gives, and
Right.
a little one can learn to listen and talk with that signal.
Correct.
Yeah. You know, what's interesting is that so when does a cochlear implant not work?
When does it not work? I
Yeah,
get that
like
question
yeah.
frequently. Then it depends on what we mean by not work. Electronically, it always works. Surgically, we can virtually always get it in. The times that it doesn't work is if the brain that we're trying to tap into isn't ready for it, or for whatever reason isn't able to utilize it effectively.
Yeah. And so particularly, like, it's usually like if there's a missing cochlear nerve then at that point, right?
Right. If there's a complete lack of development of the cochlear nerve or even the cochlea, then that can be a problem.
Yeah.
That's a good point.
And that's more rare, though.
It's
more the exception.
Quite unusual.
Yeah. So along that line then, how does a family know if their child is a candidate for an implant?
Well, hopefully by that stage, the family that we're talking about is working with a pediatric audiologist and preferably a team that's able to constantly monitor the child's progress or lack of it and keep the family informed about whether the child is a candidate for cochlear implant. In broader terms, cochlear implant's appropriate when hearing aids are not sufficient to provide the crucial exposure to speech stimulation early in the developmental stages of the child's brain when it's ready to move quickly in terms of developing spoken language. Preferably that team has high expectations for what the child's going to be able to do and will be monitoring speech and language milestones. And if the child falls off that progression of milestones or is not meeting the progression appropriately, then it's time to think about alternatives, and that's cochlear implants.
Yeah. So it really is such a time as this because we have this wide variety. We have a continuum of hearing technology that we know most of the time we can deliver access to sound to that brain.
Right.
And that's what the terrific news is about today's technology.
It's an exciting time.
Yeah, it's really terrific. So along those lines, you've mentioned that you've been doing cochlear implants now for 25 years. And so at what age can a child receive an implant today?
Historically, the answer to that is the age has dropped down every few years. Back in the old days, the good old days, it was a 2-year-old threshold, mostly because at that point in time, a child had to be 2 to be able to be sure that the hearing loss was appropriate for cochlear implant. But as we began to recognize the importance of providing the cochlear implant stimulation earlier, the age moved down to 18 months, and then the FDA approved moving it down to 12 months. But that's the FDA labeling. That's the sort of strict official criterion. In fact, it's perfectly legitimate to do what's called off-label use of a medical device like a cochlear implant. And in fact, we do 6-month-old children whenever it's appropriate now. So 6 months is pretty much the lower threshold now, 6 to 7 months.
Yeah, so it's really shifted. I mean, like you mentioned the good old days. It's now it's about accessing that brain earlier because we know the outcomes are better. So really, a family needs to get connected with a surgeon, with a cochlear implant neurotologist, a cochlear implant surgeon, a cochlear implant team sooner rather than later.
Absolutely.
Yeah, and so I think the other thing that comes about, are you doing 6-month-old babies at this point?
We are, yes.
Yeah. So as you have parents come in, it's, we're in this business of cochlear implants. It's easy for us to say, yeah, we should implant at 6 months of age. But as parents come into your office and you start seeing them, I'm curious, what's some of the most common questions that parents ask you?
Understandably, the parents are concerned about the safety of it. It's a daunting thing to have the prospect of having your child undergo an operation like this. And I think it's the surgeon's job is to reassure the parents that, yes, it's a big thing for this family, but in reality, it's something we do all the time. And as far as the safety of the surgery, statistically, it's very safe. The possibility of life or health-threatening problems is very remote. The likelihood of the outcome we're looking for, which is a successful cochlear implant insertion, is very high. And that's usually, parents, sometimes they'll ask that, sometimes you can tell that's what they're thinking, and they might not actually ask it, so we sort of volunteer that information for them.
Yeah, and so along that line, what else do they maybe ask you, or do you want to make sure that you've talked about?
Well, I'm fortunate to have parents usually who are already well informed before I get to them, and so they're basically asking, well, how quickly can we get this done? How about next week? Or how about today? So we have to slow them down sometimes.
Yeah, and so do you get the question of how do you know it's going to work for them?
Yeah, that's a good question, and I think it's legitimate to say that electronically we're confident that it'll work, and we're quite confident given normal anatomy or MRI or CT scan that looks appropriate that we can be quite confident that it'll work well. And the limiting factor is how hard they're willing to work at helping the child develop the capacity to use the hearing that we give them.
Yeah, so and that involves wearing that implant or that hearing technology all waking hours because it's about getting that signal to the brain.
It's crucial.
And then participating in early intervention that focuses on learning to listen and learning spoken language.
Right.
Yeah. So here's a big question. 1 ear or 2 ears? And do you do them at the same time or do you do them at 2 different times?
Yeah. One of my mentors was fond of pointing out that God gave us 2 ears for a good reason. Your brain is set up to utilize the subtle distinction between the right and the left ear, and there's no doubt that 2 ears, given that both ears have serious hearing loss, and there's no doubt that 2 ears are better than 1. The crucial thing for young children is to get that first one in there so as to minimize the developmental consequences of what we call auditory deprivation. So
Yeah.
one is better than none, but not as good as 2.
Okay. So when do you decide if you're going to do simultaneous, meaning both ears at the same time?
Sure. Well, experts will differ about that. What we do now is we do one at a time. primarily because our goal is to get that auditory stimulation with speech into the child's developing brain as quickly and as seamlessly and as with as low a chance of problems as possible, and that means getting the first one done at an early age. So we do one and then do the second one at an appropriate interval.
Yeah. So from your medical standpoint, is length of under anesthesia, is that a consideration that you take in?
That is a concern for the last few years. The studies have suggested that length of anesthesia is a problem potentially for developing children if they have neurological issues, and repeated anesthetics is an issue. So we want the anesthetic duration for one procedure to be less than 3 hours, and hopefully do as few general anesthetics as possible.
Sure, and that's where experience of a cochlear implant surgeon really comes into play.
Sure, getting in and out of there quickly is a priority. So.
Yeah. So in terms of like your perspective and your seat on the bus as the neuro-otologist, what tips would you give a family whose baby's been newly diagnosed and they're considering an implant?
Sure. Well, I think it's important to give the family permission to have an emotional response. The majority of the time, a family with the new shock that this child has a hearing loss has no exposure to hearing loss. They don't have a family member. They probably don't have an acquaintance that has hearing loss. And so we give them permission to not be expert about it, but try to help them understand the importance of quickly becoming educated.
Yeah.
And that means finding professionals whose core mission it is to do this work, because time is crucial. The brain is going to develop either with hearing or without hearing, so we need to move quickly. If the family's goal is spoken language, and usually it is, we've got to move quickly and not get caught up in the emotional turmoil that sometimes occurs.
Yeah. So, I think another thing that comes into mind is we hear this all the time is, well, let's wait for newer technology. Let's wait for hair cell regeneration. What's your typical response that you give to families and have that discussion with them?
Sure. Well, if you read about hearing loss, you'll quickly come across the fact there are scientists looking at a cure for what you could call a cure for hearing loss. In other words, fixing the inner ear. That's a great goal, but the reality is it's not going to be available for us soon enough to deal promptly with the developing brain of a young child who needs to hear well. And so we can't. The technology is here now. We have a solution. It may not be as good as will be available in 20 years, but 20 years is a long time down the road. So that's a concern. We don't want to wait for new technology. And we don't want to, the other mistake I hear parents thinking about sometimes, well, let's wait till the child's a little older and can participate in this important decision. That's a mistake too. The parents have to take responsibility for the primacy of hearing spoken language at an early age in order for the child's brain to be able to develop appropriately.
Yeah, so it really becomes a family needs to decide what is their desired outcome. They have to think 3 years, 10 years old, 16 years old, but they have to act urgently today. If they want their child to listen and talk, they need to be doing those things urgently and quickly because of that window of critical period of development.
Time is of the essence with children's hearing loss.
Yeah. So I think that is really a terrific considerations that we've talked about. I hope that it's been helpful. I want to say thank you to you for joining me this evening, Dr. Baker. And you've been a good friend of Hearing First. And I invite you to check out a blog post that he wrote regarding middle ear troubles that I think you'll find extremely helpful. And also, I want to encourage you that if you'd like to learn more about Dr. Baker and his practice, you can find his website at omcok.com and learn more about his work here that he does. And if you'd like to join the discussion and further discuss about cochlear implants and candidacy and implants, come join. If you're a family member, come join other families who are having those dialogues and those discussions in our family support community. There's lots of families who are in there who have might be a little bit further down the road that can give you really terrific insights as well. And then if you're a professional, come join the professional learning community where we're learning and up-leveling our practice as well. I invite you to come stay up on all the listening and spoken language latest information. Sign up for our newsletter and come visit our website. And we look forward to continue to connect with you in online spaces. So thank you for joining us.